Chronic mesenteric ischemia is a diagnosis of pattern recognition. The patient does not come in clutching the abdomen. She comes in thin. She has been losing weight for months, and she has quietly stopped eating. Today we build the pattern that finds her. We will walk the splanchnic anatomy. We will see why the gut tolerates one blocked vessel and not two. And we will follow one patient from a missed clinic visit to revascularization. Let's begin. Meet our patient. A 68-year-old woman comes to clinic with 6 months of abdominal pain. The pain is dull and cramping. It sits in the middle of her abdomen, and it starts about 20 minutes after she eats. She has lost 30 pounds without trying. She has had 4 separate workups, an upper endoscopy, a gallbladder ultrasound, a computed tomography scan of the abdomen, and a colonoscopy. All of them were read as normal. Keep her in mind. Every mechanism we cover today is written on her chart. Here is where we are going. First, the anatomy. 3 arteries feed the gut, and they talk to each other through a rich collateral network. Second, the mechanism. Why a meal is a stress test for the splanchnic circulation. Third, the clinical triad and the red flag that changes everything. Fourth, the workup. Duplex, computed tomography angiography, and catheter angiography. And finally, treatment. Open revascularization, endovascular stenting, and the nutrition problem that outlives the operation. Listen to the shape of the history. The pain is dull and cramping and sits around the umbilicus. It is not sharp and she cannot point to it with one finger. It begins 15 to 30 minutes after she eats and lasts 1 to 2 hours. Big meals are worse. Fatty meals are worse. Small meals she tolerates. And here is the part that matters most. She is not anorexic. Her appetite is fine. She has learned that eating causes pain, so she has stopped. That distinction is the whole diagnosis. Now the history that reframes everything. She has coronary artery disease and has been stented twice. She has peripheral artery disease and gets calf claudication at 2 blocks. She has hypertension and high cholesterol. She has smoked half a pack a day for 50 years and still smokes. Atherosclerosis is not a local problem. It is a systemic one. A patient with claudication in the legs and angina in the chest can have angina in the gut. The splanchnic bed is simply the one we forget to ask about. Her exam is almost normal. She is thin with temporal wasting. Her abdomen is soft. No guarding. No rebound. Perhaps mild tenderness around the umbilicus. You may hear an abdominal bruit. You may not. The bruit is neither sensitive nor specific, and it has never made or excluded this diagnosis. What you should notice instead is peripheral. Diminished pulses in the feet. Bruits over the femoral arteries. The vascular exam outside the abdomen tells you more than the abdominal exam does. Stop for a moment. 4 studies looked for a mass, a stone, an ulcer, a stricture. All 4 were normal. And they were normal because they were asking the wrong question. None of those tests images the arteries. A standard computed tomography scan of the abdomen without arterial timing will not show you an occluded superior mesenteric artery ostium. The pathology here is not in the wall of the bowel. It is in the vessel that feeds it. Let's look at that vessel. To understand why this disease hides for so long, you have to understand the plumbing. The gut has a redundancy problem in reverse. It is so well collateralized that it can lose an entire artery and say nothing. That redundancy is why the diagnosis is late, and it is why the workup has to be deliberate. 3 arteries come off the front of the abdominal aorta. The celiac artery supplies the foregut, stomach, duodenum, liver, spleen, and pancreas. The superior mesenteric artery supplies the midgut, from the distal duodenum all the way to the proximal transverse colon. That is the largest territory, and the one that matters most here. The inferior mesenteric artery supplies the hindgut, the rest of the colon, and the rectum. Remember the superior mesenteric artery takeoff angle. It is narrow and it comes off at a slant. That detail returns when we talk about emboli. Now the collaterals. These 3 vessels are not independent. The celiac and the superior mesenteric artery are joined by the pancreaticoduodenal arcades. The superior and inferior mesenteric arteries are joined along the colon by the marginal artery of Drummond and by the arc of Riolan. And the inferior mesenteric artery connects down into the internal iliac circulation through the rectal arteries. So blood can be rerouted. Occlude one vessel slowly, and the others enlarge and take over. The patient feels nothing. Here is the number to carry out of this video. Isolated single vessel disease is usually silent. The collateral network compensates completely. Symptoms typically require significant stenosis in 2 of the 3 vessels, most often the celiac and the superior mesenteric artery together. And because atherosclerosis progresses over years, the collaterals have time to enlarge. So the disease is well advanced by the time the first meal hurts. Late presentation is not a failure of the patient. It is a feature of the anatomy. So if the vessels are narrowed but collaterals are carrying resting flow, why does anything hurt at all? The answer is that the gut has a resting demand and a working demand, and a meal is when it goes to work. Follow the cascade. A meal arrives and the gut goes to work. Digestion and absorption are metabolically expensive. Normally, splanchnic blood flow rises substantially within 20 to 30 minutes of eating to meet that demand. But a fixed atherosclerotic narrowing sets a ceiling on flow. Resting demand fits under the ceiling. Postprandial demand does not. The bowel wall shifts to anaerobic metabolism, and the patient feels a deep visceral cramping pain that she cannot localize. This is angina. It is just angina of the gut. This mapping makes the disease intuitive. In the heart, a fixed coronary stenosis causes pain on exertion that is relieved by rest. In the gut, a fixed mesenteric stenosis causes pain on eating that is relieved by fasting. In the heart, a change from predictable exertional pain to constant rest pain means the plaque has thrombosed. In the gut, exactly the same thing is true. Teach it this way, and residents stop forgetting it. Exertion for the heart, eating for the gut. Now the piece that makes this look like cancer. The pain is reliable. Every meal. Every time. Within weeks, the patient makes the connection and starts avoiding food. This is sitophobia. Fear of eating. She shrinks portions, then skips meals, then drops whole food groups, and the weight comes off. 20 to 40 pounds is common. Muscle goes with it, so a thin, wasted elderly patient with abdominal pain gets a cancer workup. And when that workup is negative, everyone is stuck. Cause and risk. In the overwhelming majority, this is atherosclerosis, and it sits right at the origin of the vessel where it leaves the aorta. Smoking is the strongest modifiable risk factor, and it is the one thing that changes the natural history. Interestingly, there is a female predominance here. That is unusual for atherosclerotic disease, and it is worth remembering. Most patients are over 60, and most have disease in another vascular bed. Non-atherosclerotic causes exist. Vasculitis, fibromuscular dysplasia, and external compression. Here is the triad: postprandial abdominal pain, fear of eating, and weight loss. Any one of them alone is nonspecific. Together in a patient with atherosclerotic disease elsewhere, they are close to diagnostic. The single most useful question in clinic is not, where does it hurt? It is what happens when you eat. And the second is, have you changed what you eat because of the pain? A yes to that second question is the finding that separates this from every other cause of weight loss. This is the single most important slide for your ward practice. A patient with known chronic mesenteric ischemia whose pain becomes constant has thrombosed. The stenosis that was limiting postprandial flow has now closed. Flow has fallen below what the bowel needs at rest. That is acute mesenteric ischemia superimposed on chronic disease, and the clock is now measured in hours. Emergent computed tomography angiography. Surgery and vascular consultation immediately. Do not schedule this patient for an outpatient study. Here is the differential that every one of these patients gets worked through. Malignancy first. Pancreatic. Gastric. Colonic. That is appropriate, and it should be excluded. Then luminal disease. Peptic ulcer. Chronic. Pancreatitis. Biliary colic. Gastroparesis. Then functional disorders. And vascular disease sits at the bottom of the list, where it is usually reached last. The lesson is not to reorder the list. It is to make sure the list has a vascular branch at all. Most delays happen because it does not. One mimic deserves its own slide. Median arcuate ligament syndrome. The patient is completely different. Young, often a thin woman in her 20s to 40s. No atherosclerotic risk factors at all. The problem is not plaque. The median arcuate ligament of the diaphragm compresses the celiac artery from outside. And here is the diagnostic clue. The compression worsens with expiration, so the degree of stenosis changes with the respiratory cycle on imaging. Treatment is surgical release of the ligament, not stenting. So you have the pattern: postprandial pain, food fear, weight loss, and a vasculopath. Now you have to prove it. And the order in which you image matters. Set expectations about labs. There is no serum marker for chronic mesenteric ischemia. Lactate is normal because the bowel is not infarcting between meals. It is ischemic only transiently. What you will find is the downstream nutritional damage: low albumin, low prealbumin, anemia, vitamin and mineral deficiencies from months of eating almost nothing. Those findings support that the weight loss is real and organic, but they do not point at the vessel. Imaging does. Here is the sequence. Mesenteric duplex ultrasound is a reasonable first-line screen. It is non-invasive with no contrast and no radiation. Its weakness is that it depends on the operator and on body habitus and bowel gas. Computed tomography angiography is the practical workhorse. It defines the stenosis at the vessel origin. It shows the collateral network, and it maps the aorta for whoever is going to intervene. Catheter angiography remains the gold standard. It is reserved for equivocal studies or for treating in the same sitting. A little more detail on each. On duplex, you are looking for elevated peak systolic velocities in the celiac artery and the superior mesenteric artery. Do it fasting. On computed tomography angiography, the arterial phase timing is what makes or breaks the study. A routine portal venous scan will miss this. Look for calcified plaque right at the ostium and for enlarged collateral arcades, which tell you the disease is chronic. On catheter angiography, a lateral aortogram profiles the vessel origins best, and you can treat while you are there. Here is a real trap. Mesenteric artery stenosis is common in older people, and most of it is asymptomatic. Finding a narrowed vessel does not by itself prove it is causing the pain. So when the anatomy and the story do not line up cleanly, there are physiologic tests. Gastric tonometry measures mucosal carbon dioxide as a surrogate for perfusion. Exercise or meal challenge testing can unmask flow limitation that is invisible at rest. These are available in few centers. In practice, the clinical syndrome still carries the decision. Once you have made the diagnosis, the goals are simple to state. Relieve the obstruction so a meal stops hurting. Prevent the acute thrombosis that would cause bowel. And repair months of nutritional damage. Those are 3 separate jobs. 2 options. Surgical revascularization by bypass grafting or endarterectomy is listed as first-line therapy. It gives the best long-term patency. The cost is a bigger operation in a patient who is often frail and malnourished. Angioplasty with or without stenting is percutaneous. Lower upfront risk. Shorter recovery. The trade-off is a higher restenosis rate and a real chance of needing repeat intervention. In practice, the choice follows the patient. A fit patient may do better with open repair. A depleted one often starts endovascular. Do not forget the nutrition. These patients arrive profoundly depleted, and that raises their perioperative risk. Total parenteral nutrition may be needed to build them up before an intervention or to bridge them through it. And when you start feeding again, be careful. After months of restriction, refeeding syndrome is a genuine hazard. Watch phosphate, potassium, and magnesium. Start low and advance slowly. Nutritional recovery takes months. The pain stops the day the vessel opens. The body takes much longer. And then treat the disease that caused it. Smoking cessation is the single highest yield intervention you can offer, and it is worth pressing at every visit. High-intensity statin therapy. Antiplatelet therapy. With dual antiplatelet therapy after stenting, according to your vascular protocol. Control the blood pressure and the diabetes. And arrange surveillance imaging afterward, because restenosis is common enough that you should be looking for it rather than waiting for the pain to come back. The pitfalls. A routine abdominal computed tomography scan without arterial timing does not exclude this, and calling it negative is the commonest error. Do not stop when the cancer workup is clean. A normal lactate means nothing between meals. Deliberate food avoidance is not anorexia, and it is not depression. Constant pain in a known patient is thrombosis until proven otherwise. An absent bruit excludes nothing. And a single incidental stenosis in an elderly patient is usually not the answer. Back to our patient. The triad in a smoker with coronary and peripheral disease pushed us to image the arteries. Computed tomography angiography with arterial timing showed high-grade plaque at the origin of both the celiac and the superior mesenteric artery with enlarged collateral arcades. 2 of 3 vessels. Vascular surgery was consulted. Her nutrition was optimized first. She underwent angioplasty and stenting of the superior mesenteric artery. She is eating full meals without pain and gaining weight. And she has quit smoking. 5 things to carry with you. 1. 3 vessels feed the gut, and a rich collateral network connects them. 2. Symptoms usually require 2 of the 3 to be significantly narrowed, which is exactly why this presents so late. 3. A meal is a stress test, and a fixed stenosis cannot meet postprandial demand. 4. The triad is postprandial pain, fear of eating, and weight loss in a patient with atherosclerosis somewhere else. 5. If the pain becomes constant, it has thrombosed, and that is an emergency. These are the sources that stand behind today's teaching. The New England Journal Review of Mesenteric Ischemia, the World Society of Emergency Surgery Guidelines, the Society for Vascular Surgery Practice Guidelines on Chronic Mesenteric Ischemia, the European Guidelines from United European Gastroenterology, and the European Society for Vascular Surgery Guidance on Mesenteric Artery Disease. Thank you for watching. Verify everything here against your own institutional protocols before you apply it at the bedside.